This is a summary of 2-hour lecture, Mineralocorticoids and Glucocorticoids. First section is very short with only 3 drugs, but second section, Glucocorticoids, has a long drug list. We will go through one by one. Okay, so let's look at Mineralocorticoids. We have to learn agonists and antagonists. Agonist only one commonly used drug. When do you use agonists? When abnormally low aldosterone level in a patient, we can use this. But just opposite, antagonist, too much aldosterone secretion in a patient. So adrenal insufficiency, we use agonists, and primary aldosteronism or Cone syndrome, we can use antagonists. Okay, let's start with the agonist. The first drug is fludrocortisone. So this is to stimulate mineralocorticoid receptors to get the mineralocorticoid activity. Indicated during primary adrenal insufficiency, that is Addison's disease, and also in secondary adrenal insufficiency. This also be effective in syncope and septic shock. We use along with the fludrocortisone and hydrocortisone. That is the common combination. So in the Addison's disease, that is a primary adrenal insufficiency, we can use fludrocortisone along with the hydrocortisone. The reason is adrenal cortex cells are not active. So since we need to replace mineralocorticoid and glucocorticoids, we are using the combination fludrocortisone with the hydrocortisone. But fludrocortisone does not have any glucocorticoid activity, only mineralocorticoid activity. Keep in mind, okay? And this is an aldosterone analog. This drug bind on to the mineralocorticoid receptor and agonize, and that will activate the receptors on the distal convoluted tubules and collecting ducts of the nephron. In the kidney, that's the target, main target, where it's going to enhance the sodium and water retention and eliminate potassium and hydrogen ions. That is the reason the adverse effect is related to potassium. We will learn that, okay? So if you know the mechanism of action, it is easy to learn adverse effects. So mechanism of action, it retains salt and water, sodium and water, eliminate potassium and hydrogen ions. Then for the pharmacokinetics, only 2 things to remember. This is actually a fluorinated drug, and it is a prodrug, and it is activated by esterases, and highly lipid soluble drug with about half-life 18 to 36 hours. Okay, nothing much to remember, but main thing to remember, the drug's indication, drug's mechanism of action, and adverse effects. Adverse effects are 2 of them. First one is hypokalemia, that is potassium is going to excrete a lot. That is the reason potassium supplement must be given. That is a must to when treated with this drug. Okay, and the second one is because it is retaining all the sodium and water, because it's going to reabsorb. That is the reason hypertension is the second adverse effects. So 2 adverse effects, hypokalemia and hypertension. It can also lead to edema, etc. Okay. Then the second class of drugs, antagonists, mineralocorticoids, aldosterone antagonists. In this one, spironolactone is the first drug and eplerenone is the second drug. So spironolactone, if you talk about, these both are potassium sparing diuretic. We learned in different lectures earlier, but let's look at what is important in this section. So here specifically aldosterone receptor antagonism indicated, we mentioned earlier, it is indicated for primary hyperaldosteroidism. Okay, And then this drug is actually have different mechanisms in different organs. Specifically in kidney, this is as effective for as a potassium sparing diuretic also. In kidney, it's going to inhibit the sodium reabsorption, but retain a lot of potassium. So that's why it is a potassium sparing diuretic. And in the heart, it can inhibit the cardiac fibrosis. So there is a cardioprotective effect in spironolactone. And in blood vessels, it can reduce atherosclerosis. And in bones, it can maintain bone calcium level. So how it can maintain the positive skeletal effect? Because it decreases the calcium and magnesium secretion. Remember, spironolactone can increase the potassium absorption and elimination of sodium, and during that time it reabsorbs calcium and magnesium ions. That is the reason this have additional benefit in bone health in elderly patients. Okay, so maybe that will be useful when you learn the mechanism and indication. What is significant to remember in this is this drug has two major adverse effects. Because it is a potassium retaining or sparing diuretic, it can cause hyperkalemia. And the second one is gender specific. In males, this drug can block androgen receptors, thus it can interfere with the testosterone synthesis pathway. That is the reason, because of the blocking of testosterone synthesis and increase the accumulation of estrogen, result in gynecomastia. So two adverse effects for this drug: spironolactone, gynecomastia, and hyperkalemia. Then what is the difference of eplerenone? This is a newer drug and it is little bit better profile, but still commonly well studied drug is spironolactone. That's the reason it is still commonly used. But this eplerenone does not have any sexual adverse effects. Okay, so it lacks spironolactone's adverse effect of gynecomastia. It is not in this drug. Okay, that is one of the difference. And another, of course, this also has that hyperkalemia adverse effect. Then next section is cortisols, like a glucocorticoids. Okay, so the first one in this one is glucocorticoid inhibitors or cortisol inhibitors. This is typically useful in Cushing's syndrome or hypercortisolemia. Very effective drugs, we can use it. Typically, Cushing's syndrome, we surgically manage this condition, but if there is no excess tissue growth there, we can use radiation and medical therapy. That is when ketoconazole is effective. Okay, so ketoconazole indication mainly Cushing's syndrome or hypercholesterolemia. How we can block the cortisol synthesis in specific pathways, because this drug can, remember ketoconazole, we learned that in other lecture, antifungal agents, remember last year. So this is an antifungal agent, but higher dose we use it here as a glucocorticoid or cortisol inhibitor. And here the mechanism is, this is actually a drug inhibits cytochrome P450 system. Here ketoconazole inhibit CYP11 and 17. This will be very, these are blocking several steps of steroidogenesis. That means cortisol biosynthesis will be inhibited by ketoconazole. That is the reason this is effective to treat hypercortisolemia or Cushing's syndrome. Okay, and two major adverse effects of these drugs are One is hepatotoxicity. Hepatotoxicity is the major one, okay? It can get into severe condition. But gynecomastia in males, similar mechanisms like in spironolactone. So we learned two drugs with gynecomastia, one in mineralocorticoid spironolactone and one is in glucocorticoids ketoconazole. And hepatotoxicity is the major one. And the second drug, levoketoconazole, that is actually a prodrug of ketoconazole, and this is a newer drug and more effective and a better pharmacokinetic profile. Same mechanisms like a ketoconazole, it block all these CYP enzymes and thus block the cortisol synthesis, right? This does not have any gynecomastia symptoms as adverse effect, but very less level, but it can cause hepatotoxicity. But another point to remember, since it is a levo that is a prodrug, also it is metabolized by, that is important to remember, it is metabolized by the liver. That is the reason if a patient has hepatic dysfunction or cirrhosis, you should totally avoid this drug because it will not be effective. Okay, so that's another point to remember. So this drug has a better response than ketoconazole and fewer liver related adverse effects. And discontinuation is lesser compared to ketoconazole. That's the difference if you ask from this drug. Okay, so the next section is actually synthetic glucocorticoids. I just put it agonist because it makes sense. What is its function? But actually we don't use that term agonist in this section, but keep in mind this is synthetic glucocorticoids. So a long list is there, but at least you need to learn this section. These are super important drugs. Okay, so let me classify it into a little bit blocks so that you will understand and you never forget these points. Okay, so the first two drugs, betamethasone and dexamethasone, these two drugs with a longer half-life, and those are fluorinated glucocorticoids. One more time, remember in mineralocorticoids we learned one fluorinated drug, that was fludrocortisone, right? So that was an agonist of mineralocorticoid. Okay, so glucocorticoid, there are two drugs, synthetic glucocorticoids. These are fluorinated, and this does not have, or minimum mineralocorticoid activity is there in this drugs. Usually the other glucocorticoids have a lot of mineralocorticoid activity, but betamethasone and dexamethasone has negligible mineralocorticoid activity. That is also a super important point to remember. So another point, these two drugs can pass placental barrier. That is the reason these two drugs are effective to use in patients in preterm labor, that is to help their baby's lung maturation. And women at a risk of preterm labor, we can use it. And what is the major point to remember? Why do you use these drugs? Reason, these two drugs, beta and dexamethasone, can pass placental barrier, and these drugs cannot be metabolized by placental tissues. This can easily pass into the fetus, and it can stimulate fetal lung maturation. So what is happening in fetal lungs? This will stimulate the pneumocyte 1 cells maturation and pneumocytes 2 cells to produce surfactant. So those are major point to remember. So lung maturation is the major role. Okay, out of these two drugs, betamethasone is more effective in lung maturation compared to dexamethasone. So that's why we are going to use that as a prototype drug. So betamethasone, if somebody asks you like how do you distinguish these two drugs, I'm giving you 2 points to remember. In betamethasone, methyl group is on the beta position, but dexamethasone methyl group is in the alpha position. That is why the name difference. Okay, both are in the carbon 16 methyl group, but don't worry about those details. But another point to remember, betamethasone has about 10-hour half-life, but dexamethasone has about 50 hours of half-life. Okay. So indication, you understood better. Both can be useful for preterm labor. You know the mechanism of also why you are using in that, right? And but betamethasone is little bit like some of the evidence-based studies proved that patients get well tolerated and less adverse effects in with a beta methasone. Okay, so these two has negligible mineralocorticoid activity. That is the reason dexamethasone, that is an oral form, we can use it in asthma exacerbation. Okay, avoiding. So the major reason is this drug also has only negligible mineralocorticoid activity. Therefore, it will not retain salt and water. Therefore, it is very helpful because we don't want much mucus and slimy, sticky mucus in the airway. So it can reduce the water content there. That is why dexamethasone is very effective. So when patient is taking this drug, like if it is an asthma patient, albuterol usually given about 5 minutes early, and after about 5 minutes, once the muscles relaxed completely, then you give dexamethasone. Okay, so just remember, so salt and water retaining properties negligible in this drug, and it has a longer half-life also, like I said, about 50 hours. Okay, that's a major thing to remember. Since we use these drugs in like a shorter time, we don't have much adverse effects, but of course, like all the glucocorticoids, there are some major adverse effects we are going to discuss in few minutes. The next drug is hydrocortisone. Hydrocortisone is actually a rapidly acting drug compared to the other drugs, right? Hydrocortisone has also a strong mineralocorticoid activity. Okay, that is the reason this drug is indicated for septic shock during. It is used as IV drug in ICU. So if you compare, betamethasone and dexamethasone cannot be useful because those do not have any mineralocorticoid activity, but hydrocortisone has mineralocorticoid activity, and there is a strong mineralocorticoid activity, very useful during septic shock. And also this is rapidly acting. That's what we needed, rapidly acting drug. Okay, so IV administration is a high dose is useful for in patients. Okay, and the next one, another commonly used oral drug, prednisone. Okay, so out of all these, dexamethasone and prednisone are the popular corticosteroids. Okay, oral corticosteroids. Prednisone is the most commonly used one. Okay, and this is actually outpatient drug, and we can use this is actually a prodrug. Okay, metabolized in, by HSD11 beta enzyme, metabolized into prednisolone, and then it will do their normal cortisone activity, right? But the second drug, prednisolone, scientists created another independent drug. That's prednisolone is normally, it is used in children. Commonly, the reason is it is a liquid form, is very sweet. They added a sweetener and make it a little bit sweeter. So kids like to use that. Okay, and methylprednisolone is the next one. This drug is given as IV and IM. Normally used in hospital setting. Methylprednisolone is very effective to deliver large doses of drugs. Okay, so needs very small dose because it is a very potent drug. Okay, this also compared to the less mineralocortical activity and long acting drug. Long acting drug, methylprednisolone acetate form is really long active drug. Okay. Then the next drug, triamcinolone, sorry. Triamcinolone is actually a topical drug. We can use it similar to over-the-counter hydrocortisone, but a very strong one. Okay, and of course IM is also available. But topical drug, we can use it in combination with the antifungal agent nystatin for skin infection, skin conditions. Okay, so these are the major drugs, but you need to learn like a major adverse effects and some general points. Okay, so let me explain two things for the mechanism. Usually corticosteroids have activity in inflammatory pathway. Reason, this get anti-inflammatory role, right, by producing lipocortin. Okay, this can interfere in arachidonic acid pathway, but it can also used as a immunosuppressive agent. That's by the inhibition of integrin synthesis. So that is a little bit different pathway. That's another point. Another point I would like you to remember, generally patients receive higher dose of glucocorticoid replacement therapy during morning time compared to evening. The reason is when you look at your cortisol production and the physiology during the normal cycle, body naturally produce in early morning, it starts secreting, and morning time the level of cortisone will be higher in our body. That is the reason you're given like that. And then let's jump into the adverse effects. Okay, that is the super important points to remember in that. So let's start with the first point. Glucocorticoids or corticosteroids cannot be abruptly stopped. So if you are stopping, this can lead to steroid withdrawal symptoms. The reason is this can inhibit because long-term therapy with glucocorticoids naturally inhibit HPA, hypothalamus pituitary adrenal cyst axis will be suppressed. That is the reason. And like from the pituitary, you will have or minimum or negligible level of adrenocorticotropic hormone secretion. So this can suppress the adrenocortical cell activity. That is the reason you need a couple of days to week to activate your suppressed adrenal gland. Adrenal cortex cells have to develop after protein synthesis. Normal cells have to develop and start secreting the hormone. That takes some time. That is the reason it is super important to remember you must taper, follow a withdrawal regimen while using the glucocorticoid or corticosteroid therapy in patients, right? That is very important. And the second important point may be osteoporosis, but just discuss gender-specific adverse effect. Okay, in male it can cause erectile dysfunction, and in females it can cause irregular bleeding and because menstrual cycle will be irregular. Okay, so reason both will affect the hypothalamus pituitary ovarian axis, and the in male it can affect the testosterone and all the hormones. That is the reason they have gender specific adverse effects there. Then the osteoporosis is another major, both in male and female it can be. Reason corticosteroids can inhibit the osteoblast activity. Remember, blast build bond, right? Accumulation of more calcium, but that can be blocked by corticosteroids because they block osteoblast cells. There is less osteoblast activity. This can lead to porous bones. Another point, osteoclast activity will go high too. That means you get more poor response, right? And also calcium reabsorption from the intestine will be reduced because of this glucocorticoids. So there is not much bone building happening. That is the reason during osteoporosis, both calcium elimination, that is calcium is not reabsorbing, and osteoblast activity is lower, both can lead to fragile bones in patients. Then another point, skin thinning, that is also a significant point. Patients get a lot of stretch mark and all, very thin skin, and the blood vessels can show very clearly see through the skin, transparent skin formation. The reason is 2 points to remember. When you talk about in epidermis, epidermal cell layer number will be, that is cell division will be very less, very thin layer of epidermis, and also keratin synthesis will be very less. And in dermis, because of the inhibition of fibroblast cells, you will have very less level of collagen secretion. Okay, so collagen proteins also will be very thin, and after some time it break down. That is the reason skin thinning is like very prominent in body. Okay, then midsection weight gain, of course total weight, you can remember just weight gain is common during this therapy. The reason is body try to make it available like a glucose and of amino acid and lipid make it available for the body's use. Body is thinking, oh my god, it is very stressful situation or emergency, that is why body has a lot of cortisol. That's what body is assuming. So it's going to start metabolizing all these like a increased fat metabolism, but it is kind of irregular. All the hormones will be dysregulating, so it will be floating around, and when it will start accumulating behind the neck, face, neck, and all this area, right? And also midsection body weight will be gaining because of that. Another thing is this can also inhibit insulin, which can lead to the increased and high blood glucose level, because body because of the high cortisol is making the glucose available to the activity, but we are not using, because normal, of course if you keep exercising and using it can regulate up to certain point, but naturally when corticosteroid has that tendency to keep all this because of the normal physiological pathway. And another point is about the protein from the muscle. Lean body, of course the body weight will be because of that fat accumulation, not because of the muscle, because muscle thinning will be there. And that's also muscle wasting is also a characteristic of this therapy. Okay, the next is cataract. In glucocorticoid has a tendency to accumulate, bind it, especially it covalently bind on the lens protein. That is the reason after some time it can lead to cataract. Okay, and last one in this list is pepticals. Of course there is a lot of other lists, but mainly I want you to remember all these 7 points. These are super important. Why pepticals? That means if a patient has already pepticals, so you should avoid this. The reason is the same mechanisms like we are talking about in skin, right? In the stomach lining, the single layer of columnar epithelial cells, those will be not be multiplying well, and also its development will be stunted, and also the decreased level of prostaglandins. All this leads to peptic ulcer in patients. Okay, so what else? I think those are the major points for this one. I don't know whether it may be 30 minutes or something, but hopefully this will be helpful for you. Review everything, and all the best. This may be useful for your board exam also. And see you in another video.